Okay, so today's topic, we are initiating our class on critical care neurology, right? And on behalf of Reliance Foundation Hospital, Department of Critical Care and Department of Neurology. And we have embarked our journey with critical care nephrology. Then we have started on oncology now, neurology. Soon we will come on critical care endo and infectious disease, right? So be with us, all of you. It's a small step towards good education practices, though we do a lot of work on online and hybrid and offline training processes. And we would, with the help of every one of you, we will try to be doing more and more programs, and we would diversify, we would include, and then we will have the third term, which is common, we will have equity on everyone's basis. So today's topic, I think we wanted to start on a topic which is getting more and more important in critical care aspect, and where the critical care physicians, with all due respect, like myself, has lesser understanding on that. And bringing two uh, specialities together on board, that we're getting a presentation from a neurology perspective with a clinical expert from both the domain of neurology and critical care. The idea is to have the best of both worlds, both the perspectives, that what is the core disease process, what is the mindset of the primary physician, and what are the outlook of a critical care physician. So it's actually an exchange of views and also the knowledge, so that we both complement each other and eventually the patient had a better outcome. So we have Dr. Abdul Mukid Sheikh, who is our DNB neurology resident. He has done his post graduation in pediatrics, and now he has completed his training in neurology for Reliance Foundation Hospital. He would be presenting under the able guidance of Professor Dr. Arun Shah sir, who is a very, very famous neurologist of our country. He had been the head of the Department of Neurology in Nayar Hospital, Mumbai, and now he is the Director of Neurology in Reliance Foundation Hospital. And he would be guiding us on this program itself. So Abdul is just sitting beside me, right? We had some sort of technical glitch, but he is going to present from here and is sharing. So over to you, Dr. Abdul.
Good evening, everyone. So it's actually an interesting topic, and most of the things are now being updated, and continuously things are going day and day. We are getting new and new antibodies and updates on this particular topic. So I'll start my presentation with 4 cases, which I will cover in 10 to 15 minutes. I'll go briefly on the cases, and then I will cover approach to autoimmune encephalitis. Particularly, I will focus on the clinical aspect, particularly what we face in day-to-day practice. And later on, Dr. Arun Shah sir will join us, and he will give his expert comments on this topic. So coming to first case, so all these cases are from our hospital only. So I have taken with Arun Shah sir's permission. I'm including these cases. So he was a 67-year-old gentleman. He presented with 3 days history of mood disturbances, behavioral changes, and uneasiness and excessive perspiration. He presented in our hospital with some social and behavioral changes. And prior to this, he was completely all right. He was having no memory or cognitive decline, no dysphagia, no other complaints. Also, when he came to us, he had on examination he had a proximal muscle weakness on both lower limb. But distally he was okay, but there was no signs of meningitis, knuckle rigidity, or no other signs. Going to his past history, he had a renal cell carcinoma, which was operated in 2018. and he underwent partial nephrectomy. Also, he was type 2 diabetes mellitus. So his previous, as I told, his previously he was no any preceding illness, no URTI, no headache, no other prodromal symptoms were there. Routine examination wise, labs were uh, not significant initially, except for hypokalemia. He had low potassium 1.7, but after correction, potassium increased with IV correction is 2.2. And after IV potassium correction, his lower limb power improved and he was able to stand. He was in ICU for all these medical issues. But later on, he developed means like persistent irritability, agitation, uh, behavioral disturbances, and some kind of psychotic this thing. Also, his potassium levels are usually remaining on the lower side. So with this psychiatric condition, we thought it may be because of the ICU environment. He was having ICU psychosis. So we started with a usual or a typical antipsychotic like risperidone and quetiapine. But and thought in view of his ICU environment, we shifted his environment to ward. But there was no improvement in the uh, behavioral and psychiatric symptoms. And despite of changing environment, despite of medication, he is same. So we did MRI brain, we did EEG, both were normal. Then we had less flu. And in view of persistent hypokalemia, we investigated. So investigation revealed cortisolemia and ACTH were high, and DEXA suppression test was also positive. So we did DOTA PET scan and CT PET abdomen, which were negative. But there were bilateral adrenal hyperplasia, which was we revealed on this one. So we thought it may be because of all this cortisolemia be because of endogenous Cushing-White syndrome, and we started with ketoconazole and added metyrapone. But his cortisol level with this treatment is improved. So later on, initially his platelet levels are 1,17,000, but later on he had pancytopenia. We thought it may be because of the drug-induced factor, and we changed it. And in view of also in view of immune suppressive status, we investigated. So we found it maybe it was low serum IgM level and IgA level. Let's see, absolute CD4 count was 78, and his CMV PCR was positive. So we started on ganciclovir. So we had the case of endogenous Cushing-White with possibly indolent endocrinal tumor or ectopic ACTH secreting tumor and associated with encephalitis. It could be or possible viral or autoimmune. So we went ahead with we wanted to do CSF and lumbar puncture because of thrombocytopenia we were not able to do, and we treated symptomatically. Uh, we did in view of high suspicion of autoimmune encephalitis, we went ahead with PET scan. So because of MRI was not suggestive of anything, but that's why we went ahead with the PET scan. But PET scan revealed basal ganglia and bilateral basal ganglia and mesial temporal hypermetabolism, along with hypometabolism in bilateral occipital and parietal and temporal lobes. So which was pointing towards um, autoimmune encephalitis. So we had a syndrome of persistent psychotic behavior, catatonic posturing, psychosis, along with this thing. So we sent his autoimmune panel in which his serum anti-NMDA receptor antibodies came positive. So Rest of the other anti-neuronal antibodies were negative. IgM herpes negative. Serial EEG was not suggestive of any uh, 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 abnormalities. Then we started treatment on the line of autoimmune encephalitis. Initially, we plasmapheresis was given for 5 days. Antiepileptic were optimized. Despite of plasmapheresis, psychiatric symptoms persisted. He was having psychosis, catatonic, mutism. Those who were there in, I think, he was admitted on 14th floor only, so they will remember. EEG was repeated, which was showing slow activity, and also he developed extrapyramidal symptoms like tremors, oromandibular dystonia, and cock-wheeling and rigidity. So, in view of no response to plasmapheresis, we escalated immunotherapy and IVIG was started. So, with the course of IVIG, his symptoms improved. So he after the course of IVIG, he was slightly better. His sensorium, consciousness, and psychiatric symptoms all subsided. Even his potassium levels also normalized. Then we were debating what to continue for his maintenance immunosuppression, but rituximab was not visible, so we continued IVIG every 3 weekly, and he gradually shows progression. So this was one case which NMD receptor. Another case I will discuss in brief. So this is Mr. GB, 60-year-old gentleman. He was admitted in 2020 before COVID. So he presented with difficulty in speech, speaking, and change in voice, imbalance while walking, impaired present and memory, altered behavior, and behavioral changes, personality changes, altered sleep pattern. All these were going through 3 to 4 months prior to presentation to our hospital. So he was having severe gait ataxia. When he presented to us, he was not able to walk unsupported. And also he had marked sleep disturbance, which he was having because of that sleep behavioral disorders. He was having frequent jerk movement and all these things. Uh, his wife not used to sleep with him in the same room because he was getting disturbed. Also, he was having daytime sleepiness and nighttime difficulty in sleeping. His cognitive assessment was revealed poor registration, poor attention, and poor recall. Rest of the things are okay. He was having marked dysphonia and dysarthria, severe bulbar weakness, and truncal ataxia. So we did MRI. MRI was not suggestive except for a few macroangiopathic changes, as you can see in the thing. So in view of suspicion of autoimmune encephalitis, we went ahead to PET scan. FDG PET scan revealed severe hypermetabolism in bilateral mesial temporal lobe and basal ganglia, as you can see here. So even frontal also frontal field, you can see frontal cortex, you can see hypermetabolism and mesial temporal hypermetabolism here. So his EEG was not normal. We did sleep studies. Sleep studies revealed REM sleep behavioral disorder. CSF was normal with 2 cells and 42 milligram protein, and paraneoplastic panel came negative. But his autoimmune encephalitis panel, including IgG1, was also sent to Amrita. So the report came IgG1 5 positive. So he started on treatment methylprednisolone for 5 days, no significant improvement. Then IVIG started, and patient improved symptomatically. And we right now he is on maintenance rituximab, and he is doing well. So this is another case. So I have included each cases from one spectrum so that you can see the varied presentation of autoimmune encephalitis, and that I will discuss why it is varied presentation. So Mr. AM, third case, 39-year-old gentleman. He was presented with episodic memory loss, change in behavior since 3 months prior to presentation, with involuntary movement of face and upper limb. Uh, and also, prior to presentation, the last 15 days, his movements were increased. Uh, and he was cognitive, he was having cognitive slowing, and whatever he used to do, his occupation, he was not able to manage. But no other systemic symptoms were there. Examination revealed recent memory was impaired, speech fluency was affected, and there was word finding difficulty. And examination wise, he had faciobrachial dystonic seizures. So intermittent dystonic movements involving upper limb and right side of the face. But rest of the examination was normal. His EEG was done, which was suggestive of bilateral intermittent run of delta brushes, which is consistent of encephalitis. So in view of that, we did uh, PET scan. PET scan again is showing bilateral mesial temporal hypermetabolism, increased FDG uptake. His routine investigation were normal, but we sent autoimmune encephalitis panel, which came LGI1 VGKC positive. We started on methylprednisolone 1 gram for 5 days, no improvement. Then he underwent plasmapheresis for 5 cycles. He had remarkable improvement after that. He was continued with oral steroid as a maintenance therapy, and later on continued with the rituximab. So in, he had significantly on follow-up. He has significant improvement in behavior, memory, and his but EEG was normalized. But he has slight residual faciobrachial dystonic seizures was still present when till last follow-up. Case 4, 72-year lady presented to us in March 2022 with cognitive decline, tremor, slowness, seizures, and behavioral changes. When she presented, she was drowsy but arousable, not oriented to time and place person. She was comprehension was impaired, poor registration. She was having hardly any spontaneous word output, monotonous speech. She used to repeat the same words. Rest of the cranial nerve was normal except for bradykinesia and rigidity in all four limb and tremors. So we had rapidly progressive dementia with extrapyramidal symptoms, with behavioral changes, with one episode of seizure. So we thought of autoimmune encephalitis, chronic meningitis, CJD, or degenerative dementia. EEG was not contributory, bilateral non-specific slowing was there. The rest of the lab investigation was normal. CSF was showing slightly increased protein level, but cells were normal. Infective markers are negative. MRI was also not suggestive of any specific etiology except for chronic ischemic changes. Then we sent autoimmune panel in suspecting high clinical presentation, but it came to be negative. We again sent serum and CSF autoimmune encephalitis panel to Amrita, which again came to be negative. His Igilon and CSF serum and CSF Igilon and antibodies also negative. So, with a strong suspicion of autoimmune encephalitis, we did PET scan, which was showing diffuse increase in uptake in bilateral basal ganglia, mesial temporal lobe, and cerebellar peduncle, with marked hypometabolism in cerebral cortex, as you can see here. These all basal ganglia and mesial temporal hypermetabolism. Even brain stem is also involved. So, in view of suspecting seronegative autoencephalitis panel, we started with solimedrol 750 mg because her weight was less than 40 kg. So we started with 755 days. Showed slight clinical improvement, slight speech improvement was there. Then we plan for IVIG and further escalation because of not much improvement, but relative wanted discharge. So again, after 3 days, she came back in ICU with worsening of the cognition, sensorium, language dysfunction, and intermittent stair loop. So here you can see a video. So actually, it's not playing. Anyway, so I'll describe. She had left side stair loop with rigidity in both upper limb, left more than right, with repetitive speech. His Her case score, clinical assessment scale in autoimmune encephalitis score worsened from 17 to 27. We repeated EEG. EEG was showing bilateral non-specific slowing. Repeated autoimmune encephalitis panel VGKC was negative. Anti-TPO was also sent, which was negative. ANA was positive 1 is to 30, 320, but ANA blood was negative. Repeated MRI was normal. Started on IVIG for 5 days, then continued with oral steroids. Antiepileptic medication was adjusted. With this therapy, she improved. We repeated IVIG for every 4 weekly, after 4 weeks for every 2 days. And with this immunosuppression therapy, immunomodulated therapy, she improved. So these are the 4 cases from 4 different categories I have included with even seronegative. So I'll brief about autoimmune encephalitis. So as we know, autoimmune encephalitis is a syndrome. It is not a particular one disease. It is actually a syndrome. It is a syndromic diagnosis, which patient present with acute, subacute, or chronic symptoms. Why it is important to understand and diagnostic approach, because it has few diagnostic challenges. Because the clinical presentation, as we have seen from the previous cases, it is varied, and there are number of autoimmune antibodies, as you can see here. And as day passes, new antibodies are we are finding. So these antibodies are varied and their targets are varied. So that's why their presentation is also varied. That's why diagnosing autoimmune encephalitis is also a challenging task. Also, we will see in subsequent slide etiology. So etiology is also varied depending on the whether it is associated with neoplasm or post-infectious or idiopathic. So you can see there are, as day passes, there is new invention of new antibodies coming into the picture. So when to suspect a patient with autoimmune encephalitis? So as I told you, the duration the symptoms should be subacute to chronic, but less than 3 months in the onset. It could be recurrent. The symptoms could be recurrent or monophasic. Most of the time, recurrent cases are usually paraneoplastic. Monophasics are usually idiopathic autoimmune encephalitis. So they will be having underlying etiology like cancer, smoking, elderly patient, weight loss history, or young patient with autoimmune diseases. All these things you need to consider. Preceding viral infection, specifically HSV encephalitis. All these usually trigger the autoimmune encephalitis. We have seen in pediatric also. We see post-viral encephalitis. They may end up with they come with extrapyramidal symptoms and all these things with autoimmune encephalitis. Yeah. So coming to classification, it could be anatomical classification based on the area of the brain involved. It could be serological classification based on antibodies we get, or it could be etiological classification based on whether it is associated associated in neoplasm or post-infectious or idiopathic, or it could be immune check mediated. So we know the antibodies against which the antibodies act. It could be intracellular antigens, or it could be a surface antigens or synaptic antigens. So most of the time, I don't want to go to all these individual this thing, because it's a quite lengthy list. So most of the time we see intracellular antigens, antibodies against the intracellular antigens are usually associated with uh, underlying neoplasms, and surface antigens, they are usually present without underlying neoplasm. So they are paraneoplastic encephalitis and autoimmune encephalitis you usually see in picture. So as we can see, the antibodies which are present in the intracellular against the intracellular antigens, they are usually associated most commonly small cell lung carcinoma, testicular seminoma, thymoma, or ovarian tumors. These are the most common tumors which we encounter. Whereas those who are having synaptic or surface antigen antibodies present against these antigens, their frequency of association of malignancy is less as compared to those with intracellular antigens. Coming to anatomical presentation of these things, so it could be the symptoms depend on the these anatomical involvement of the brain. So it could be limbic encephalitis, which may present with cognitive impairment, psychiatric symptoms, epileptic presentation, or it could be cortical or subcortical involvement of the brain matter, like here you can see. So they may present with cognitive decline, seizures, or especially refractory seizures. It could be diencephalic involvement or periaqueductal involvement. They may usually present with autonomic disturbances, sleep disturbances, or it could be striatal involvement like basal ganglia and deep gray matter. So they present with movement disorders, extrapyramidal symptoms, or they may present with like a brain stem encephalitis. So they will present with symptoms of craniobulbar weakness and involvement. Or it could be meningoencephalitis. They may present with meningeal irritation, symptoms of meningeal irritation, and altered sense of hearing. Not only they will present with a CNS manifestation, as you can see in this slide, they may be associated with some syndromes with peripheral nervous system involvement, like neuropathies, autonomic neuropathy or ganglionopathy, or NMJ involvement, or myopathies. So we have got the overview, like it can present, it has a varied presentation depending on the antibody involvement. So how we approach? So first and first most thing which we learn from the day one of our medical school is history and examination. So history and examination is critical while formulating hypothesis of autoimmune encephalitis. So usually acute or subacute onset are like autoimmune encephalitis. Usually they are subacute to chronic. Particularly chronic ones are like LGI, Casper2, DPPX, GAD, or other neurodegenerative disorder. If they present with hyperacute, there will be less likely it could be a autoimmune encephalitis. More it is like a vascular etiology. As I told you, it's monophasic, usually idiopathic, and it is if it's a progressive or recurrent, it could be paraneoplastic autoimmune encephalitis. So in this slide, I have included the clinical clues which you can formulate what antibodies we can underlying etiology and underlying antibodies associated. So as it's a detailed slide. So the most commonly NMDA receptor and EMPA receptor or GABA B receptor in antibody mediated encephalitis, they usually present with psychosis, psychosis, dystonia, chorea, like extrapyramidal symptoms and psychiatric manifestations. Status epilepticus usually present with GABA B receptor or GABA A receptor antibodies. Like, and as I told you in the previous case, LGI1 antibodies, they usually present with faciobrachial dystonic seizures. We have two cases, both have faciobrachial dystonic seizures. One of the patient was having underlying CA breast, which we diagnosed on the PET scan. Neuromyotonia, muscle spasm, fasciculation, they usually present in the Casper-2 mutation. So these are not the only symptoms present. There will be another associated symptoms will be present, but there is these, if these are the present, then you must think of the underlying antibody involved, like stiff person syndrome, GAT65, glycine R, and amplifycin receptor antibodies they usually see. And cranial neuropathies are usually present with Ma, Hu, and Hu, and Miller-Fisher-Vegas stuff. These are the all bulbar involvement or brainstem encephalitis. So, as we see, most commonly we encounter with NMDA receptor antibodies. They usually young, particularly especially female. Less commonly, we see LGI, GABA B, Casper, and with the decreasing frequency, I have arranged it. So, Igilon is very rare, but we have two cases we diagnose on the basis of symptoms, particularly sleep disorder. They usually present with sleep disturbances, bulbar weakness, and along with the associated symptoms.
I will interrupt you on that. When we send the entire panel of autoimmune encephalitis, do all these markers are being, or all these antibodies are being checked?
Yeah.
Or do we have to specify that according to the symptom that these are to be
DPPX and Igilon are we usually have to tell, but most of the panels they usually include NMDA receptor, VGKC. VGKC include LGI and Casper2 and GABA A, GABA B receptor. So all at least these five receptors we
commonest are included.
Yeah,
by default. But regarding DPPX and Igilon,
these are
according
very,
to the
yeah,
clinical situation, you
We
can
have
specify.
Yeah.
Then only they would include.
Correct.
And we always see that you send it to the Kochi. So is it only place in India that all these receptors are being or there are other
sensitive,
centers too?
specifically the sensitivity of diagnosing these antibodies differ with the method used. So these cell line culture method they usually do in Kochi, which is, which is very highly sensitive.
So you are saying the both the methodology and the process efficiency are better with this particular cell.
Correct, because we have we have seen a few reports negative from outside lab, but when we repeated the same thing from Kochi, it came positive. When we inquired, we realized that the method used to do this assay are different, and the sensitivity will differ with the method used. So one more important diagnostic methodology is imaging, like MRI brain, and CT scan will not show anything. So MRI brain and PET scan. So even with PET scan imaging and CT brain imaging, the hyperdensities which we see in the MRI imaging, we can probably diagnose what is the etiology, underlying etiology. Like in NT-WHO, we'll see mesial temporal lobe sclerosis. I have included a table in later slides. So I'll show you most specific regions of the brain where most common autoimmune antibodies.
So with the proper, you are saying, go back to the previous slide, that with the proper MRI and with a proper good person to interpret also. So not only we diagnose the disease, but we can specify the etiology also.
Sure. Yeah. With like imaging, most of the time MRI, as we have seen in the previous cases, MRI will be normal. So we have to go with the other imaging modality, or we have to go by the antibodies. So depending on all these things, we have to collectively take a call. But most of the time, we get signature. Some clinical presentations, like, or some diagnostic presentations will be signature presentations. So that will be straightforward thing.
So combination of your signature symptoms and the markers, particularly the autoantibodies, which can be done through CSF analytics, and very specified targeted imaging tactics or a approach strategy.
Yeah.
These all three things just like a mathematics, you can pinpoint the disease as well as the etiology.
Right. So I'll go to the diagnostic criteria.
I think sir has.
अब्दुल बोल रहा है ना
Yes, sir.
5 मिनट
Sir,
5 मिनट
I'm done, sir. Few more slides are there. So
हेलो हाँ
yes, sir.
क्या बोलिए
We are at imaging, sir. I have briefed about antibodies associated with autoimmune encephalitis, clinical presentations.
Yeah, I know.
and,
I'm listening. I'm reading a bit.
Yes, sir.
I think it's quite
So-
exhaustive.
Yes. It's quite lengthy. Even I want like participants also can join in the discussion.
No. What
that
I
we
think
will
we
be
have
able
to get a message. Basic concept is when should you suspect? That's what you should teach here, and then
Yes,
we
sir.
decide. And then what are the typical syndromes of NMDA? What is the typical syndrome of LGI? What is the typical syndrome of Igelon-5? What is the syndrome of GABA B receptor? You know, if you can summarize that for them, that would be the best thing to do.
Yes, sir. So I have shown them when to suspect the autoimmune encephalitis, like
So
subacute
what are the
presentation.
criteria? What is it? Just summarize that.
Yes, sir. So criteria I have included in later slides. So that's what I wanted to discuss. Okay, I have included this and I have conveyed it. So coming to our part of presentation. So imaging is also one of the important modality, especially if the MRI is negative, then we have to go ahead with the PET scan, because practically we are seeing PET scan, the sensitivity of picking up the abnormality is higher than the MRI. And it is also supported by one article, one paper published by named Hans. So they also concluded that the sensitivity of PET scan is more than the MRI. So any specific area involved in specific antibody mediated.
Can I interrupt here? What I think the
Yes,
problem
yes, sir.
is, so that let's see, in many of the autoimmune encephalopathies, MRI may be totally normal. There are certain encephalopathies where MRI is abnormal. One of them is GABA B receptor, which shows white matter changes. Limbic encephalitis of LGI variety will pick up abnormalities in the mesial temporal area. That is called limb typical, you know, abnormalities in the hippocampus and mesial temporal region. So these two are characteristic. In most of the other, MRI is normal, and that's why sometimes PET scan is useful, as Dr. Abdul is indicating. So whenever you suspect, do not rest only on MRI. You must go to FDG PET scan, which can show you the abnormalities which are not seen on MRI.
Sir, then should we straight away go for the FDG scan, or we still sequentially go through MRI and?
I think we go through MRI with the idea that you can't make a diagnosis of, you cannot rule out structural lesions there. When the clinical syndrome is saying sometimes structural lesions, strokes, vascular dementia remains a possibility. That's why we need to do MRI just to make sure that you know how brain structurally is, you know.
So MRI will rule out the other differentials. And if we do not get anything specific on the line of, even we have a very clinical suspicion of autoimmune encephalitis, then we move towards the FDG PET.
Correct. Absolutely. Okay. But there are characteristic changes in certain diseases in the MRI, and that was these two you have to remember. GABA B receptor, and which shows multifocal white matter changes, it will be seen, and limbic encephalitis, either paraneoplastic or LGI1, which will show typical limbic abnormalities in the mesial temporal grid.
Yes, sir.
Okay.
And even sometime we may not get antibodies. Sometime we may get negative for all autoimmune encephalitis patterns. Which this one case of Suman Arora I have discussed in earlier with this slide. So where we diagnose on based on the PET scan only, because MRI was normal, EEG was also not normal, CSF was not contributory, and
So,
autoimmune encephalitis was
so
negative.
that I think the point there is that we have not categorized all the possible antibodies as yet.
Yes, sir.
Every year some new antibodies are detected. So you may not, you know, even if panel is negative, does not necessarily mean it is ruled out. But then we don't have a support on it. So MRI definitely helped her case to increase our suspicion further.
Yes, sir.
Sir, can you little bit emphasize on that, because we right now have a as you have termed as seronegative autoimmune encephalitis. So if you
Yeah.
can please explain it to
No,
the
I think
audience.
this. I think if your clinical syndrome is not like uh, vascular dementia or Alzheimer's or anything like that. So if your clinical syndrome is odd, even if your pattern is this thing is negative, we are looking for some support. So there, FDG PET scan sometimes gives you support, and sometimes we decide to treat them, even though the panel is negative, because it's well known all over the world. Okay, we are still have so many unidentified antibodies, surface marker, which can give you a clinical syndrome, and it will come positive later on. So in fact, the dementia panel, which Amrita Institute gives, there is a last thing is non-specified neuronal antibodies. That means there are neuronal antibodies, but I am not able to categorize. That kind of report we get nowadays from Amrita Institute and Mayo Clinic also. So I think
Okay, so
that is
that means that it is not the methodological flaw. Rather, these are yet to be discovered
correct.
markers. Yeah, yeah,
Yeah, you I think
uh,
you put it exactly correctly. Yeah.
fair.
So, as we discussed, the criteria, it could be for diagnosis of autoimmune encephalitis is subacute onset with at least one of the following symptoms like focal deficit, seizures, or CSF pleocytosis, or imaging. I'll rather include MRI or PET scan. Suggest your specific signature
So
changes.
I think Dr. Abdul, here we must specify that this subacute onset or 3 months history does not apply to Igilon 5,
Yes,
because
sir.
Igilon 5 syndrome can go on for 2-3 years before we make a diagnosis. So
Yes,
that
sir.
is one thing you should remember, that most of the syndrome, other like NMDA receptor and all that, this applies. 3 months history, 3 to 6 months history is enough. But if you
Yes,
have Igilon 5, you should suspect it even after 2 years of history, because with the diagnosis, the syndrome may be so atypical that you don't make a diagnosis with up to 2 years. As I told you, the New England Journal paper, which
right.
I showed you, there the motor neuron was diagnosed for 3 years. Then the sleep onset started, and when the sleep disorder started, oh, they thought, oh, it could be Igilon. Bulbar symptoms and sleep onset, and then it came out to be positive. So it's important to remember that the subacute onset history, it does not apply to Igilon 5 syndrome.
Yes, sir. So that's why when I gone through the literature, so I
Uh,
got this recent article from AN,
uh,
which were earlier, whatever the diagnostic criteria were there, they have all discarded, and something new diagnostic criteria they usually present. And actually, it is varied presentation. This is a syndrome, the syndrome of different etiology, different
correct,
clinical
correct.
presentation. So we can't we can't diagnose it with one single criteria. So we have to be open for so that it varied presentation should be included in our diagnosis.
Correct. So now that is what I wanted you to summarize. Okay. For example, we know that if you have bulbar palsy, sleep disorder, the one should think of or PSP like phenotype, think of Igilon 5.
Again,
Similarly, limbic disturbance, think of LGI1. If you have paramyotonia, peripheral cramps, pain, and encephalopathy, think of capsule 2. So like that, if you have GI disturbance, diarrhea, and
PPPH.
this you should think of DPPX. Then if you have syndrome of hyponatremia and limbic disturbance, think of LGI. So
Yes,
some
sir.
these are the clinical clues which you should summarize for them to how to suspect. Okay.
Yes, sir. So I'll go ahead what sir has told. So I'll go back to that same slide so that this could be registered in this thing. So this is the important slide, what sir was wanted to focus. So specific, apart from all these things, if you get like status epilepticus, so you may suspect GABA B, GABA A receptor antibodies, hyperechlepsia, so glycine receptor antibody encephalitis, or faciobranchial dystonic seizures. So LGI1 should be in your high on card. Neuromyotonia, muscle spasm, fasciculation, Casper 2, and even like gastrointestinal hyperexcitability, what sir has mentioned, like DPPX, and bulbar symptoms and cranial neuropathy. So you must think of Miller Fisher and all this thing. In bulbar also, Izilon also we must do. And also I have shared one slide where you can see not only the CNS manifestation, but also peripheral nervous system involvement in the form of neuropathy or neuronopathy. So you must consider autoimmune encephalitis along with this thing, like even ganglionopathy, neuromuscular junction disorders, or myopathies. So what sir has also pointed out, and specific symptoms pertaining to a specific syndrome, like marked sleep disturbance, bulbar weakness, stridor, diverse movement disorders. So Izilon 5 should be in high on card, and uh, myoclonus, hypercalexia, prominent diarrhea, weight loss. So DPPX should be in on your suspicion. So likewise, we may think on these lines.
Now, let me ask sir and you both that why do we need to put so much on effort to have a very pinpointed specific diagnosis? Is it due to prognostication, or we have a separate approach on the treatment itself?
So definitely, the treatment response to immunotherapy varies with the underlying etiology also. And also, if we have a specific treatment, as I told you, okay, there will be either it is cell surface antigen or synaptic antigen or it's intranuclear antigens.
Right.
So if it is antibodies against the intranuclear antigen, we must extensively search for underlying malignancy, because the highest possibility of underlying neoplasm is there. Or even if you don't find the neoplasm at the diagnosis, we must continue
Looking
to
for it.
search for till 3 years or 5 years after the diagnosis of autoimmune encephalitis, and it is
So,
advisable.
the autoimmune encephalitis can precede the overall florid
Definitely.
manifestation of the malignancy process. So it
Yes.
should be continued, and maybe the treatment of the primary malignancy could be curative for the autoimmune encephalitis itself,
Yes,
right?
yes.
So that's it. Okay.
That's why the identification of antigen is the antibody is important. So I'll quickly summarize the treatment approach. Because the time is the constraint, so I'll summarize it fast. So acute immunotherapy and maintenance immunotherapy. Acute immunotherapy, usually we start with a high dose corticosteroid, and there were 1 gram per day for 3 to 5 days, and treatment of underlying hmm, malignancy. And as we discussed just now, these paraneoplastic conditions are usually resistant to immunosuppression. So what sir has, Arindam sir has pointed out that the treatment response will be different with the underlying autoimmune antibodies. So alternative therapy, if there is a failure of initial immune suppression. It could be either IVIG or cyclophosphamide, or it could be rituximab. So most commonly we usually use IVIG and rituximab. And such patient need a long-term immunosuppression, because the recurrence is also possible. As you can see, the graph of disease progression. So long-term immunosuppression is with rituximab or maintenance corticosteroid or maintenance IVIG usually advised, and it is advisable to bridge the immune suppressive therapy, oral prednisolone or periodic intravenous methylprednisolone.
But he already come there. उसका video हो गया था. He had paid for video, ना?
Sir,
sorry.
sir, this is for the, how do we choose that? Should we go for the first line in all the patients, or we have some options that rather than going for a plasmapheresis, we should go for a rituximab or an IVIG? Is there anything specific, or the treatment is very streamlined?
Yeah, I think it's a individualized decision. I think this is a acute treatment and maintenance treatment. Acute treatment, you can start depending on the clinical syndrome and how patient is sick. We should start with one drug and that goes other.
Okay,
I think it has to be individualized. But Solimedrol sometimes helps. If it doesn't help, then go to plasmapheresis and immunoglobulin, which the order can vary. One could do plus plasmapheresis and then IVIG, and then maintain them on immunosuppressive, I think long-term steroid, along with when you have azathioprine or mycophenolate or rituximab, depending on the syndrome we decide. But I have been preferring rituximab these days, particularly IGL-5 and others. It's better. I think last few patients, all of us autoimmune are all on maintenance rituximab, and they're doing well.
Yes, sir. And this also depend on the patient's clinical condition, hemodynamics, and other comorbidities like IVIG and plasmapheresis. We usually, if the patient is hemodynamically stable, and all this is a collective decision depending on the situation.
So, but still, I think what sir is saying, that the preferred drug is steroids itself, maybe plus minus a plasmapheresis, immunoglobulin, and maybe for the long-term immunosuppression, sir, you are preferring rituximab. And this is very quite obvious. Almost 50% of patients all over the world is getting rituximab on that. Okay.
So also need for searching of underlying malignancy. If the antibodies against the intercellular antigens are present, we need to continuously search even after the primary diagnosis, even till 3 to 4 years, every yearly. Ideal modality is PET scan. And for antibodies against the neuronal surface antigen, there will be no clear-cut guidelines for searching the underlying continuous searching of the or continuous screening of the underlying cancer. So take home message is,
have you clarified? Finish it off there. Yeah. Sorry.
So take home message is, autoimmune encephalitis is a spectrum of disease with neurological and psychiatric symptoms, along with even bulbar and other peripheral nervous system involvement also. So there is a presentation is very that's why it poses diagnostic challenges because of the lack of specificity of the diagnostic test. Also, there are many unidentified intracellular and extracellular protein receptors. Hence, negative serology panel for antibodies should not delay the initiation of treatment of the primary modulatory therapy. And strong clinical suspicious of a disease is mainstay of, to identify the seronegative encephalitis, and early recognition and initiation of therapy is also important in long-term neurological outcome. Thank you very much. Over to you, sir.
Sir, I think Abdul has an excellent presentation and quite an exhaustive. Sir, while being on that live casting, I'm getting messages in the WhatsApp that the presentation had been very nice, and we should do critical care neurology very often, provided you get the time. Sir, one thing the audience wish to know that what are the differential? I think you had a slide, but
Yes,
you had a
because of the lack
Sir,
of time.
let's hear from sir. That what are the major 3-4 differential that we should always exclude before pinpointing towards it?
No, I just told you, it's a clinical syndrome. For each particular antibody, there are certain clinical syndromes which are features which support the diagnosis. I think the basic differential obviously is the differential diagnosis of rapidly progressive dementia, if it is a dementia presentation. So many other things like slow virus disease and all that will come in the picture. Metabolic, toxic, Wernicke's. Like last time we were thinking that it could be
Wernicke's,
rapid progressive Wernicke and turned out to be Wernicke's, So
Yes, sir.
all those one would go to the rapidly progressive dementia syndrome, and whatever is underlying in the differential diagnosis will probably come here also.
Okay. So
And the other important thing is, I think the Dr. Abdul must have pointed out that unfortunately the therapeutic the options for intracellular is very poor, and prognosis is also very poor. And I don't think they do. We have few of them where we have a diagnosis paraneoplastic syndrome. We made a good diagnosis, but we have not been able to treat. At least I know of that lady with cerebellar degeneration along with CA breast, and she's still not completely all right. I mean, she's deteriorating despite IVIG and everything. So we have limitations for intracellular antibodies, which are basically in relation to paraneoplastic syndrome.
Sir, is there a distinct difference in prognosis in between the two major divisions, that is neoplasm related or non-neoplasm related?
Oh, definitely. Neoplasm related are not treatable. And even if your treatment is only treatment of primary malignancy, which may halt it, but they never get cured. While non-neoplastics are definitely, like for example, you have limbic encephalitis. If it is paraneoplastic, whatever you may do, ultimately dementia goes on to dementia. While if you have autoimmune like LGI, I mean, they respond beautifully. They become normal.
Sir, how long do we need to, in a non-neoplastic patient, how long do we need to do a chronic immunosuppression?
That
Is there
I
any
think
fixed rule?
no, that question is not settled as yet. I think I was the American Academy last year had a session on autoimmune, and I have a recording of that. I can show you guys if you want to. But the question is probably not answered. Generally, we say every 2 to 3 years. Whether serious serology will help you, I am not sure, because it's LGI or the Mr. Brambert case, which Dr. Abdul pointed out, the Igilon 5, and now we are following up for last 3 years. And I gave him rituximab even few days ago, because his Igilon is still positive. Now, whether it will become negative ever and I will be able to stop, the question is not answered. So I think that all will depend, but generally people believe at least first 3 years is a must. Only I remember a lady of NMDA receptor, which I had diagnosed when I was in Saifi few years ago, that I have stopped all the treatment and she's cured. So we gave her treatment for only 3 years. So generally, I would say after 3 years, one should really look at it, whether it is required or not. But up to 3 years, so we must give.
And this is purely on the biochemical based, or it's a combination of clinical and biochemical?
Clinical and biochemical. If so, they have to go into remission clinically, and then you keep on doing NMDA. And if the NMDA came negative, then I said, now you stop it. And somehow our decision was correct. She's all right now. But important thing is that she had an ovarian teratoma. So we removed it. So that's why she's cured. So I think that may not apply
multimodal
to
approach. So you the precipitating as well as sir, some your pulse of wisdom for, because most majority of the audience is critical care. So these patients when come to ICU, so how are the ICU people, intensive care people should be aware of and should be doing?
I think you should, as you know, just try to remember the syndromes which occur in ICU. Like this man we picked up who presented with respiratory failure under Nimesha, and I had seen him a month before, where he had presented with spasmodic dystonia and mild bulbar weakness, and then he went into respiratory failure. So I was not happy with this. So we did not get a typical history of sleep disorder, but I said he's presented with bulbar symptoms and now he's going to respiratory failure in a very short span of 1 month. Let us do IGLON 5, and it came out to be positive. So I think the issue, you should have high index of suspicion if you find odd things to go on, and that.
So I think better good awareness about the subject, that this is a quite not so uncommon disorder.
Correct.
And it can have a myriad of presentation. So if anything unusual, we should have the high index of suspicion and consult quickly a neurologist to rule out on that part. So that is it. And once we have a diagnosis and others, what are your expectations from intensive care people, sir? What we should be doing correctly?
Oh, that I think what critical care you are giving is good enough. I don't think there is anything else we expect from you, except we take a timely decision and treat them properly.
I think also you would be happy to have a good infection control, because a lot of your immunosuppression would be happening on that part.
Yeah, that
Sir,
is
any
correct.
also how many of these people could have a bulbar dysfunction, so that these people have a higher risk of aspiration and aspiration related pneumonias?
I think many of these disorders probably have it. Yeah? So bulbar weakness is of course common only in IGLON 5, but other disorder will be or encephalopathy, often dead. Like the lady with NMDA receptor was so bad, she was on ventilator for almost 3 to 4 weeks, and we had to do her removal of ovarian teratoma while she was on ventilator. And in fact, the gynecologist I referred to says, "You wait. Let it recover, then I will remove the teratoma." I said, no, I want it to be removed now. So he has written up that Dr. Shirish Shahid, a senior gynecologist, he wrote up that I had to do a removal of ovarian teratoma in a lady on ventilator, and he wrote up that article. So he was so surprised that first time in his life he must have done that. So
right, sir. Any more questions from the audience? Because sir had to leave. Any more questions from the audience? No, I can't see any more questions. I can see Hemal sir and all others. Sir, we will be coming back on the acute neuromuscular disorders in critical care in the month of January. I will seek your permission for the exact date, but we'll come back on this. So I think there has been quite a request that at least once a month, if we can do a critical care neurology.
Sure, we'll do that.
Okay, sir. Thank you. Thank you, Dr. Abdul.
You.
And thank you, sir, for joining us. Very special guest.
Thank you, Mr.
So we will come back on the month of January, and Happy New Year, and have a great year end for all of you. And thanks for joining today. Thank you.